Her anterior and posterior side, sorry. Yeah.
No, you're good. I think
Yeah, you can see them. Same steps as it was before. There's only one side on her stethoscope, so we don't have to turn it or anything like that. Also don't really have to warm it up, already pretty warm. And since we already chose the locations we're gonna be doing, I'm just gonna go for it. I'm gonna go right side, left side, back and forth, and I'm gonna listen to one full breath through at each location. All right, I'm gonna have you sit straight up. Sorry.
Yeah.
And then take a deep breath. Okay. Go ahead. Just gonna use the outside
Yeah, you're
of my
good.
hand. I'm gonna ask you. Perfect. One more. Okay. I did 7 points there. You only have to do 6, but I'm overachieving. I also forgot to mention, I would ask my patient not to hyperventilate while they were breathing, just take very long, slow, deep breaths, which she did. And I heard no abnormal breathing.
You do it by
Oh, yeah, now I'm gonna do the left side. Crap. Yeah, I'm just gonna do it now.
I was gonna say, you could just probably say
Completely
it,
forgot. I'm gonna stand up and do it here. Go
but you can
ahead.
move too if you want. Like,
Good. Thank you. Just do one more. And there we go. Okay, now I'm gonna do the posterior pulmonary auscultation on my patient. I also forgot to mention, but I'm looking for normal sounds. Any cracking, wheezing, or ronchi is abnormal, and I would probably assume that something is wrong. Anterior side though, there was none of that. So professional, I'm so sorry. All right, and then I'm also asking my patient to cross her arms and kind of hunch over, moving her shoulder blades out of the way so I can just listen better. All right, and then I'm just gonna take a deep breath. Okay, again. Again. And I'm good. There's not more points marked here. I'm just gonna go under your brow. Go ahead. One more time. Okay. And then down here. And one more. Now one more. And I did it on that side. I'm gonna go to the other side now to do it bilaterally, but on this side there were no abnormal sounds. Go ahead. Okay. One second. Go ahead. And one more. Perfect. And then they were all normal. Perfect. Yep. So I'm just gonna go. First, I'm going to find her aortic valve on her left side. I'm coming in on the right, and I know exactly where that is, right there. And I'm just gonna ask you to take a deep breath for me. Okay. And I'm gonna go directly across right here and do the same thing for her pulmonic valve. Go ahead. Perfect. And now I'm going to move down to her tricuspid valve. Thank you.
Herb's one.
Now I'm going to ask you, well, that was Herb's point. Now I'm going to go under right here. Take a deep breath for me. Okay. And I heard all the normal lub-dub sounds, so
Thorax, okay? Alright, so first I'm going to inspect the patient. I'm going to look at her rate and work of breathing. She is breathing at an even rate right now. You know, she's not working to breathe, not struggling, so her breathing looks pretty normal. She's not in any signs of distress right now. So her rate of breathing is good. From there, I would palpate her chest for subcutaneous emphysema. It would feel like little crackles underneath my fingertips whenever I palpated if she had subcutaneous emphysema. And I don't feel anything, so that is not present, which is a good thing. We don't want that. And then I would assess the patient and feel for vibrations whenever she says the number 99, and this is tactile firmness. I want to feel these vibrations, but they need to be equal on both sides when I feel. So go ahead and say 99.
99. 99. 99.
Okay, so the vibrations on each side of her chest were equal, and so the tactile firmness was fine. Now I'm going to listen to my patient's lungs. And she's taking a good deep breath for me each time I place my stethoscope on. Okay, and there I use the ladder method going back and forth between each side to hear any differences in the lungs. And she does not have any adventitious lung sounds. She sounds clear, no crackles, bronchi, anything like that. So now that I've assessed the front side, I will go ahead and assess the posterior side of the patient and her lungs. So to begin, I'm going to look at her back and look at how she's breathing, see if she's using any accessory muscles to breathe. And she is not. She's breathing pretty evenly at a normal rate. And then from there, I'm also going to assess tactile firmness on the patient's back as well. And so I'm going to have her say the number 99 as I move my hands down her back. Okay?
99. 99. 99. 99. 99.
Okay, so those vibrations on both sides were really equal. No dissimilarities in the differences there with this patient. So from there, I can percuss, and I'm going to be percussing to find the diaphragmatic excursion. And so what I'm going to have her do in just a minute, I'm going to have her take a deep breath and hold it. And as she's holding it, I'm going to percuss down, top down to the bottom, and find where the resonance ends and the dullness begins. And then after that, so I'm going to go ahead and do that actually before I explain the rest of it. I'm going to go ahead and have her take a deep breath and hold it, and then I'm going to percuss. And right there's where I heard some dullness. Do on the other side. Okay, and I heard some dullness right there. So you can go ahead and breathe. And right there is where I'm going to go ahead and mark my line. Right there on this patient is where I heard the dullness start. Now from the bottom up, I'm going to have her, in just a second, take a deep breath, exhale it all out, and hold that exhale for me. And I'm going to percuss once again from the bottom up, and I'm going to see where the resonance begins and the dullness ends, to find out where the width of my diaphragm is. So I'm going to go ahead and have you take a deep breath in, and exhale it, and hold. And right there is where I heard that resonance begin. And so right there is the width of that. And so it should be around 3 centimeters, 3 to 6. In athletes, it can be 7 to 8 centimeters because, you know, they have a better ability to expand their lung volume and that sort of thing. So now that I've percussed the patient, I can also listen to the lung fields on the back. So I'm going to use the same ladder approach, listening from side to side and check for the lung sounds bilaterally. Deep breath in. And once again, no adventitious lung sounds with this assessment of the patient, no crackles, nothing like that present in the lungs. And so that concludes my assessment of the lungs. So now I'm going to go ahead and assess her cardiac function. So I'm going to start by palpating her carotid pulse. I'm going to only feel on one side of the patient's neck for the pulse because if I feel on both sides at the same time, she can pass out because you're blocking blood flow to the brain. I'm going to go ahead and feel for that. And her pulse is not bounding on either side. It's very even, and it has, you know, it's not bounding. So I check the carotid. Now I'm going to have the patient recline at a 45-degree angle. I'm going to have her turn her head that way for me, and I'm going to look at the point where her jugular is pulsating. This is then called the jugular venous pulsation. And so I'm going to go ahead and check that. And I'm going to take 2 rulers. One is going to go on her clavicle, and the other one is going to go at the angle of the pulsation of her jugular. In patients with cardiac dysfunction, or they may have cardiac abnormalities, that pulse can be seen up higher in the neck, but on this patient it is where it should be, which is right here at the right at the base of the clavicle almost. And so we're going to go ahead and measure that now. So I've got my ruler and I've got my other one. And I'm going to measure the angle at which that is looking. And it should be no more than 3 centimeters. And this patient is 3 centimeters, so that is a normal finding. Like I said, if it's more than 3 centimeters, it can indicate some cardiac dysfunction. So in addition to my cardiac assessment, I'm going to go ahead and palpate some areas of the heart, beginning with the apex. And I'm going to be feeling of the apex of the heart, and I should feel that at the 4th or 5th intercostal space, mid-clavicular line on the patient, and this is the PMI. Now I can feel her heart pulsating at that point. Now I'm going to check for heave, and so I'm going to put my hand right in the middle of the patient's chest and feel if her heart is pounding or anything like that. And it's not, I don't feel any lifts or anything like that, and her heart is not beating out of her chest. And then I'm going to check a thrill, which are just some vibrations. Sometimes you can feel vibrations with your fingertips at the 2nd intercostal space right here. And if you do feel vibrations, they should be even on both sides as far as feeling of the heart. So then from there, I can listen to the heart. So I'm going to take my stethoscope and I'm going to listen with the diaphragm of the stethoscope at the beginning. And I'm going to feel first right here on the right at the aorta, rather. I'm going to feel again at the pulmonic valve. And again over here at the tricuspid. And at the mitral valve. Now, with the bell of my stethoscope, I can listen again to the mitral and the tricuspid valve. And with the bell of my stethoscope, I'm able to hear murmurs better, and it's able to help me listen to adventitious heart sounds, or abnormal heart sounds rather, with that bell of that stethoscope. So with heart sounds, I should hear lub-dub, which is S1 and S2, which I did with this patient. If you hear an S3, that is an abnormal sign, and it could be some signs of some cardiac dysfunction. So we don't want to hear S3. But this patient is a very healthy patient. And then if I also want to hear some aortic stenosis, I would hear like a bruit over the, right here at the aortic valve right there. I'll listen over that, and if there was some aortic
throat. So now I'm going to move on to the thorax and lungs, okay? So first I'm looking, everything looks great. I'm going to go ahead and palpate, and you tell me if you have any tenderness anywhere, okay?
Okay.
Any tenderness over here?
No.
No on this side?
No.
Check out the back?
No.
Yep. Okay, so now I'm going to actually have you face over here, if you don't mind. A little bit more at an angle. Okay, so now I'm going to ask you to say, I'm just going to tap on your chest a little bit, okay? So, sorry. Okay, so now I'm going to have you say 99 every time you feel my hands touch your chest, okay?
Okay. 99. 99. 99. 99.
Okay, perfect. So now I'm going to go ahead and auscultate at the front really quickly, so just go ahead and breathe normally. Okay, now at the back, go ahead and face up corners a little bit. Okay, breathe deeply. Okay, now every time my stethoscope touches your chest, say E.
E. E. E. E. E. E. E. E.
Okay, now say 99.
99. 99. 99. 99. 99. 99. 99. 99.
Now whisper 1, 2, 3.
1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2,
Okay, perfect. That should be it for your thorax and your lungs. So now we're going to go ahead and move on to your cardiovascular and peripheral vascular exam. So first I'm just looking. I'm going to go ahead and palpate for any heaves, throws, or lifts, okay? Oh, down here, sorry about that. I'm palpating for your point of maximal impulse. That's at your midclavicular line at the hip intercostal space. Okay, just holding the time. Probably supposed to lift up the hand. Everything seems good. So now I am going to sorry about that, I have one brain. So I'm going to listen to your what's it called? Your carotid. Is it okay? Mm-hmm. Okay. Before I continue in consultation, I'm just going to go ahead really quickly and look at your cap refill, okay? So hands, 1, 2, 3, 4. That looks great. Now I'm going to go ahead and just get them listening. Sorry about that. Okay. So, first with the diaphragm, aortic, pulmonic, verbs, tricuspid, mitral, and same with the bell. move over and lay on your left side. I'm gonna go ahead, I'm gonna listen to the microphone one more time with the bell. Okay, great. Now go ahead and stay.
Next up, I'm going to be inspecting your chest. So upon inspection, I see that the skin is appropriate for ethnicity. There are no scars, lesions. There is no abnormal hair distribution, so that is also good. So I'm going to be inspecting from the front and then from the side. So it should be about a 1 to 2 ratio, which it is. And upon inspection, I also see no use of accessory muscles, so that is good. You have no issues breathing at all. Everything sounds great. So next up, I'm going to wipe down my stethoscope because I'm going to be auscultating your respiratory sounds. Okay. Now, before I continue any more, do you also have any more questions? All right. So, anytime I move on a spot, I'm gonna have you take a deep breath in and out through your mouth. Right now, I'm gonna palpate for your clavicle. And while I do this assessment, is it okay if I reach into your bra at certain points? Okay. All right. In through your mouth, up through your mouth. Okay. So in order to do these next few steps, I may have to go in a little more, and then I'm gonna have you lift your breasts at the end, okay? Deep breath. Again. Okay. So, like I said, I'm gonna have you lift up just a little bit. Alright, deep breath. Okay, on the side. Okay. Alright, so now I'm going to be listening to your posterior side. So if you would just lift your legs up onto the bed, it's a crisscross applesauce. I'm going to move your hair to your front a little bit. There you are. Now once again, I'm just going to move the stethoscope, and each time take a deep breath in and out through your mouth. Alright, upon auscultation, I did not hear any adventitious sounds. Your breaths sound rhythmic, so that is also very good. I'm going to be assessing your heart sounds again, so you can put your feet back down on the floor. Now, when I do this assessment, I may stop in a particular spot, but don't get alarmed because I'm just going to be taking your apical heart rate. So in the process of doing that, please do not speak or anything, okay? Again, I'm going to be going in just a little bit, okay? Okay, and now I'm going to ask you to lift up on your left side of your breast. Thank you. So since I'm able to hear it a little better at Herb's point in the middle, I'm going to be doing my apical pulse up there, okay? So your apical rate was about 75 and it was rhythmic. S1 and S2 was heard in all 5 spots. It was just easier to hear at Herb's point, so I used that for my apical rate. So yes, 74, which is good, it's within range. So that is perfect. So now
front and a couple places on the side. And for that, I'm going to have you sit up where you are in a comfortable position for you. And then the way we're going to do this is every time that I touch my stethoscope to your chest, I want you to take a deep breath in and out through your mouth, okay? Sorry. I'm going to move on to this right side, okay? Good. And then this left side. Perfect. So your lungs on the front, anterior lobes sound good and clear. Same for your sides. Your lateral lobes sound clear as well, okay? The next thing I'm going to do is listen to the back side of your lungs. So if you could swing your legs off the bed for me. And then same thing here for the breaths. Every time I touch my stethoscope, in and out through the mouth, okay? Good. So your posterior lobes of your lungs also sound clear. I don't hear any abnormalities in any places for your